welcome to Insight Ophthalmology. This is Dr. Amrit, welcoming you to another important lecture in diabetic macular edema. Today we are studying the important landmark clinical trials in the management of diabetic retinopathy and diabetic macular edema. So in this lecture, we shall be studying first about the clinical trials which tell you about the importance of control of sugar levels. Then we shall be studying about the trials on ranibizumab, then the trials on aflibercept, and finally we shall be concluding with the important protocols of the drcr.net. So first of all, let's talk about the blood sugar level control, and the two important trials which come under this are the diabetic control and complication trials, which is commonly referred to as the DCCT. And now the second trial which comes under this is the United Kingdom Prospective Diabetes Study, that is UKPDS. Okay, now it is very important to know what is the difference between these two trials. Both of them, they tell you about the importance of blood sugar control. However, there is some difference between this DCCT and UKPDS trial. First, let us talk about what was this diabetic control and complications trial, also referred to as the DCCT. Now, the DCCT trial actually told us about the importance of blood sugar control, specifically in the type 1 diabetes, that is the insulin dependent diabetes mellitus. So it told you that the tight blood glucose control in patients with type 1 diabetes reduced the cumulative incidence of macular edema at 9-year follow-up by 29%. Okay, and moreover, it also reduced the application and the need of focal laser treatment for diabetic macular edema by half. Okay, so the DCCT trial is basically associated with the control of blood sugar levels in type 1 diabetes. Now, the second trial for the control of blood sugar was the United Kingdom Prospective Diabetic Study. This study, in contrast to the DCCT study, is actually telling you about the control of sugar levels in type 2 diabetes. Okay, so it told you that tighter blood glucose control again can reduce the need for laser treatment at 10 years by 29%. Okay, and when the person is not able to control the sugar levels, then the laser treatment is about 78%. Okay, the need for laser treatment is about 78%. So you can see that just by controlling the blood glucose level, how much there can be an improvement in the diabetes macular edema. Apart from that, the UKPDS study also mentioned about the importance of reduction in the blood pressure. It told that the mean systolic blood pressure, if it can be reduced by 10 mm of Hg, and diastolic blood pressure, if it can be reduced by about 5 mm of mercury, then also there will be a reduction in the requirement of retinal laser treatment. So in this way, these two important studies, that's the UKPDS and the DCCT study, mention to us the importance of control of blood glucose levels and blood pressure in managing the diabetes macular edema. Now we shall be discussing about the trials, the clinical trials which are related to the ranibizumab. So the first trial is the READ3 trial, okay, or the READ3 trial. Now this was a very simple trial in which two different doses of ranibizumab were actually compared, and these two doses were the 0.5 milligrams versus the 2 milligram dose of ranibizumab. And as we all know that it is the 0.5 milligrams which was proved to be superior to the 2 milligram dose of ranibizumab, and that is the reason why we are using this dosage now. Now the next important study for ranibizumab is the RISE and the RIDE clinical trial. Now this RISE and RIDE study basically studied the long-term outcomes and efficacy of ranibizumab therapy in patients who had diabetic macular edema, right? So here we had three arms for treatment. First was the ranibizumab 0.3 milligram. That means the entire patients, all the patients were actually randomized to these three treatments. Okay, few of them received ranibizumab 0.3 milligram dosage, few of them received ranibizumab 0.5 milligram, and the other received sham injection. So here adults who were above 18 years with diabetic macular edema were enrolled. The central subfield thickness was usually taken to be more than 275, and the study eye best corrected visual acuity of 20 by 40 to 20 by 320 was taken. Okay, now they were subjected to 3 treatments, that is ranibizumab 0.5 milligrams. Few of them received, as you can see, 250 received ranibizumab 0.3 milligrams, and another 257 received a sham injection. Right now, they were actually, the treatment was continued till about 2 years, that is about at months 24, and the endpoint was the visual acuity gain of more than 50 letters on the ETDRS score, on the ETDRS chart. Now they were also followed later on up to about 36 months. Okay, so now what was observed was that, as you can clearly see from this diagram, the above graphs actually are representing the ranibizumab treatment, whether they received 0.5 milligrams or they received 0.3 milligrams. Okay, and the lower one is representing the sham injections. Okay, so definitely, as you can see, that the improvement in the visual acuity score is much better in those patients who received ranibizumab compared to those patients who did not receive ranibizumab. However, is there any conclusion regarding the dosage, whether 0.3 milligrams is better or 0.5 milligrams is better? No, there's no conclusion. Both of them gain equal, almost equal scores when it comes to the improvement in the visual acuity. However, that was definitely, it proved that the ranibizumab treatment is better compared to the sham injections. So it told you that the strong visual acuity gains and improvement in the retinal anatomy and also visual acuity, which was achieved with ranibizumab at the month 24, were sustained through the month 36 as well. Okay, so in the rise and ride, we first observed the patient up to 24 months, and then again they were continued, the observation was continued up to 36 months, and the result was that whatever visual acuity or retinal anatomy, that is the OCT anatomy improvement, which was gained at 24 months, was also maintained at 36 months. Okay, now delayed treatment in patients who were receiving sham treatment did not seem to result in the same extent of visual acuity improvement observed in patients who were originally randomized to ranibizumab, and therefore this tells you that ranibizumab is definitely superior to the sham treatment. Now coming to the next trials, and these clinical trials are basically for the aflibercept, which is also called the VEGF trap. Okay, and the other name from aflibercept is Eylea. Now the VINCI trial, the primary purpose of this, the VINCI trial, that is the DME and VEGF trap eye investigation of clinical impact, that's the full form of the VINCI. It was basically a phase 2 double masked trial. Okay, phase 2 basically means that it is actually done in the patients, but the number of patients which are selected for the trial in phase 2 is much lesser compared to that in the phase 3. Okay, now the double masked trial means that neither the patient nor the administrating doctor knows about the drug that is being administered to the patient. Okay, now the main purpose was to determine whether different dosages and dosing regimens of intravitreal aflibercept were superior to the focal laser photocoagulation, and the study duration was selected to be about 24 weeks. Okay, so this was also testing in patients who had diabetic macular edema, but here the comparison was being done between the focal laser and the different dosing regimens of the aflibercept. Now here the 5 treatment arms were actually selected, and the patients was assigned randomly to one of these 5 treatment groups. So some of them received 0.5 milligrams of aflibercept every 4 weeks. Then some of them received 2 milligrams of aflibercept every 4 weeks. Then few of them were receiving 2 milligrams of aflibercept for the initial 3 month, that is the loading dose, and then every 8 weeks. Then the fourth group was 2 milligrams of aflibercept for the initial 3 monthly doses, that is the loading dose, and then later on they were given aflibercept as and when needed, which is called the pro-renata regimen. And the fifth group was that who were receiving the modified ETDRS macular laser photocoagulation. So you can see that in this we are basically comparing the aflibercept to the photocoagulation. However, there are different types of regimens for aflibercept that were actually compared in this DA-VINCI study. So what happened? you can see that the laser group definitely performed poorly compared to the aflibercept groups. Okay, so very similar to the rise and ride, it also told you that the aflibercept is definitely better than the laser group. However, which dosing regimen is better in the aflibercept, whether it is the loading doses of 2 milligrams, or is it the 2 milligrams every 4 weeks, or is it 0.5 milligrams every 4 weeks, that could not be concluded from this study. So, the DaVinci study actually told you that the intravitreal VEGF trap eye, also called the ILIA or the aflibercept, it produced a statistically significant and clinically relevant improvement in the visual acuity when compared with the macular laser photocoagulation in patients with diabetic macular edema. Now, another study which came for aflibercept in a much wider group of population, and this was actually the phase 3 study, was the vivid and vista study. Okay, and the main aim was very similar, to compare the efficacy and safety of intravitreal aflibercept injection with macular laser photocoagulation for diabetic macular edema, and here the duration was about 3 years, so much longer than the DaVinci trial. So here also patients were selected, and they were subjected to 3 treatment arms. So one of them were given the intravitreal aflibercept 2 milligrams every 4 weeks. Then they were given 2 milligrams every 8 weeks, and this was obviously after the initial loading dose. And the third group was subjected to laser photocoagulation. Now, it was seen that the visual improvements which were observed with both intravitreal aflibercept regimens, whether it is the 8 weekly or it is the 4 weekly, was quite similar when you observe it at 52 weeks or if you observe it at 100 weeks. And even at 3 years, as the duration of study was observing the efficacy of the aflibercept over a long duration of time. Okay, that means 3 years, which comes to approximately 148 weeks. It was seen that the visual improvements were maintained even at week 148 with similar overall efficacy in both the groups, whether it is 4 weekly or it is an 8 weekly group. So, after all these studies, the recommended dosage of aflibercept for DME, which was given by FDA, was 2 milligrams to be given every 8 weeks. However, this was to be done after 5 initial monthly injections, which will be the loading doses. Now, in the latest study, this has been challenged by a company which is claiming that, according to the Photon trial, the primary objective of the study was to determine if we can treat the patients with diabetic macular edema by using a much higher dose of aflibercept. Now, we know that in the initial one, we are using the 2 milligram dosage. At present, we are using this 2 milligram dosage of aflibercept, which has to be given about after 5 monthly injection loading dose, and then thereafter you have to give it every 8 weeks 2 milligram. Now, according to this latest trial of Photon, it says that the high dose of aflibercept, which can be given at an interval of 12 to 16 weeks, will provide a non-inferior best corrected visual acuity compared to aflibercept dose every 8 weeks. So what they are trying to say is that if we use a much higher dose of aflibercept, maybe the interval can be increased from 8 weeks to 16 weeks duration between the subsequent aflibercept dosages. So this they are going to go to the FDA for the approval. However, at present, what we are following is 2 milligrams of aflibercept after 5 initial monthly injections, after which you have to give 2 milligrams of aflibercept every 8 weeks. So FDA has only recommended the 8-week interval in the dosage and administration section. So this is very important for you to know. Now coming to the DRCR study protocols. Okay, the DRCR stands for Diabetic Retinopathy Clinical Research Network, and it gave a lot of protocols which are very useful for us. The most important of these is the Protocol T. The Protocol T actually is a comparison between the 3 important anti-VEGFs for diabetic macular edema. It is bevacizumab, ranibizumab, and aflibercept. So these 3 medications were given randomly to the patients and to observe favorable effect in diabetic retinopathy. So in this protocol T, as I told you, patients more than 18 years with type 1 or type 2 diabetic retinopathy, and they will have center involved diabetic macular edema OCT, visual acuity scores 20 by 30 or 20 by 320 were noted, and usually the protocol T enrolled those people who had not received prior treatment or received very minimal treatment for diabetic macular edema. And then these patients were subjected to aflibercept, bevacizumab, or ranibizumab. And the duration outcome was studied at 1 year and then also at 2 years. And the outcomes that we were studying was the change in the visual acuity and the change in the central subfield thickness on OCT. So, what was the results of this protocol T of DRCR? Protocol T said that the aflibercept was much better than ranibizumab and bevacizumab at 1 year duration. However, if you follow up the patient at 2 years, what was noted was there wasn't much difference between aflibercept and ranibizumab. Obviously, these two were better than bevacizumab, but as such, at the 2 years landmark, there was not much difference between aflibercept and ranibizumab. The next protocol that we have of DRCR is the protocol I. The protocol I basically compared the ranibizumab monotherapy for diabetic macular edema. And how did we prove that ranibizumab alone can be useful for diabetic macular edema is by having 4 arms in the study. The first arm was focal or grid laser alone. In the second arm, patients received ranibizumab along with prompt focal and grid laser. And the third one was ranibizumab with deferred focal or grid laser. That means the laser treatment was given after 24 weeks of starting the ranibizumab treatment. And the fourth arm was intravitreal triamcinolone plus the focal or grid laser. Right. So as you can see that the sham one, in which the patient received only the grid laser, they had least amount of visual acuity improvement. The IVTA was next. And definitely the patients who had ranibizumab along with laser, they were much better compared to the sham and the IVTA with laser. Moreover, if you compare the patients with ranibizumab with prompt laser, that means those which were given laser simultaneously with ranibizumab, and the ones which received deferred laser, that means laser after 24 weeks of starting ranibizumab, the effect or the outcome is almost similar. So that indicates that ranibizumab deferred laser is also as good as prompt laser, and that is how we arrived at that ranibizumab monotherapy can also be good for diabetic macular edema without using the laser. Okay, so monthly ranibizumab is best for diabetic macular edema, and focal or grid laser, even if you want to supplement the patient with this laser, it is better that it can be deferred for more than 24 weeks. Next, what we have is the protocol S. The protocol S basically evaluated ranibizumab for the proliferative diabetic retinopathy. Okay, we know that the ranibizumab is good as a monotherapy for diabetic macular edema, but what about the proliferative diabetic retinopathy? We already know that for proliferative diabetic retinopathy, the laser is suitable option. Okay, the panretinal photocoagulation. Now in this protocol S, they compared the prompt panretinal photocoagulation with deferred panretinal photocoagulation plus ranibizumab for PDR. And what did they find out? They found that the ranibizumab alone, that means the monotherapy of ranibizumab, was non-inferior to panretinal photocoagulation even in a case of PDR. That means it is as good if not superior to panretinal photocoagulation. However, does it mean that for the proliferative diabetic retinopathy we go on and we give ranibizumab and not do a panretinal photocoagulation? No. Okay, so the present day application of protocol S is that the panretinal photocoagulation is still the mainstay of treatment for the proliferative diabetic retinopathy, and ranibizumab has special indications, like if a patient has PDR with DME, then you can give ranibizumab for DME and probably do a PRP for PDR. Moreover, if there is a tractional component present in PDR, which is very common, it is better to avoid ranibizumab because that can lead to tractional retinal detachment. Another problem is that in a patient who has been treated with anti-VEGF and that patient is lost to follow-up, there seems to be worse anatomical and visual outcomes compared to those patients who are lost to follow-up after a panretinal photocoagulation. So that's very important for you to know. So PDR treated exclusively with anti-VEGF, such patients have to be very, very carefully selected because of the problems with lost to follow-up cases. And moreover, what I would say is that PRP and anti-VEGFs are not mutually exclusive. They have to be combined clinically for a better result. Coming to the protocol U. Protocol U actually evaluated in a short term the combination of dexamethasone with ranibizumab for patients who are dealing with refractive or what do you say, the refractive diabetic macular edema. Okay, so here there were two arms. The first arm received dexamethasone plus ranibizumab, and the second arm received ranibizumab alone in the eyes who had persistent diabetic macular edema and visual impairment despite the previous anti-VEGF treatment. So what was observed was that this combination treatment definitely was something better on anatomical level. That means the central subfield thickness was coming down, as you can see here in this graph, in the patients who received ranibizumab plus the dexamethasone compared to those who received only ranibizumab. However, when it comes to the visual acuity mean change, you can see both of them are performing almost similar. So what can we conclude? We can conclude that the dexamethasone implant was much more useful in reducing the OCT macular thickness in non-responders or refractive diabetic macular edema. However, when it comes to best corrected visual acuity improvement, it was not very helpful. Now, another protocol is the protocol V. The protocol V actually tells you about the treatment for center involving diabetic macular edema in eyes which have good visual acuity. Right? So, good visual acuity here was taken according to the ETDRS and it was taken about 20 by 25 or better. So, how did so they actually they had again three arms. In the first, patient received aflibercept anti-VEGF. In the second, they received laser, and the third was subjected to just observation. The results suggested that patients with center involvement diabetic macular edema and having good vision, that is 20 by 25 or better, can actually be managed initially with observation and close follow-up. So you need not give anti-VEGF to such patients. Now, of course, there's another study called Panorama study in which the ongoing phase 3 clinical trial is comparing the intravitreal aflibercept to sham injections even in patients with severe NPDR. So here we are talking about patients in which the proliferative changes have not yet developed. Okay, so the goal of Panorama study is to determine whether anti-VEGF treatment has a role in this NPDR and severe NPDR changes. So that's all for today. Thank you and have a nice day.